Okay, so we'll get started now. So today we'll start with lateralized or localized blood flow abnormalities. So we'll start with this case. So when you look at the chest radiograph, what might you suggest as the diagnosis here? So we have one answer so far. Okay, so we'll give you 10 more seconds on this one. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And what did we say? We said no, not double aortic arch, not pulmonary artery hypertension, but pulmonic valve stenosis. So you need to be able to recognize this on the chest radiograph. So notice that the main pulmonary artery is enlarged, the left pulmonary artery is enlarged, but the right pulmonary artery is normal in caliber. And when we have that configuration of enlargement of the main and the left pulmonary artery with a normal right pulmonary artery, the first thing we're going to think about is pulmonary valvular stenosis, which gives you poststenotic dilatation of the main and the left pulmonary artery, but the right pulmonary artery will remain normal in caliber. That is how you differentiate this appearance from the appearance of pulmonary artery hypertension. With pulmonary artery hypertension, the right pulmonary artery also will appear enlarged. And the reason we get this configuration is that the left pulmonary artery is continuous with the main pulmonary artery, so the poststenotic dilatation extends from the main pulmonary artery into the left pulmonary artery. The right pulmonary artery comes off at an angle, so that is normal in caliber. So you need to be able to recognize that appearance as the appearance of pulmonary valvular stenosis. So here's another case where we have an asymmetric appearance of the pulmonary arteries. You see that the right pulmonary artery here is enlarged, but the pulmonary vessels here on the left side appear small. And this was a case where patient had surgery for a PDA, but unfortunately there was inadvertent ligation of the left pulmonary artery, leading to the decreased blood flow there to the left lung. Okay, so here's our next case. So we notice that, first of all, the heart seems to be shifted towards the right side. We look at the lungs. It looks like the right lung is smaller than the left lung. I'll notice some patchy ground glass opacity here in the right upper lobe. We also notice that our left pulmonary artery here appears enlarged. And here is the CT appearance of this case. So I'm asking you two questions here. First, what is your diagnosis based on the appearance of what we see on the CT? And second, what is the cause of this consolidation in the right upper lobe? All right, so we'll give you 5 more seconds on this case. For those of you having trouble, notice the main and the left pulmonary artery. Something seems to be missing here. What is the diagnosis? Here we do see a small looks like a small interlobar vessel there. And what's causing the consolidation? So what did we say here? We said not bronchial atresia, not Swire-James. No, there's an absent right pulmonary artery. Yeah, so this is called proximal interruption of the right pulmonary artery. But nobody was able to give me a hypothesis or an explanation for the consolidation in the right upper lobe in this case. So let's talk about this. This is congenital interruption of a pulmonary artery. So this usually occurs, it's congenital, usually occurs between the pulmonary trunk and one of the pulmonary arteries. And so that vessel may be interrupted or extremely small. The branches distal to the interruption are usually patent and can be fed by bronchial collateral arteries, and the ipsilateral lung is usually hypoplastic. Now, there are two categories of this. The interruption may be on the side opposite the aortic arch, and therefore this usually occurs on the right, and there it's usually an isolated abnormality. Most of these patients will be asymptomatic. A small percentage can develop pulmonary artery hypertension. On the other hand, when interruption occurs on the side of the arch, that's usually associated with cardiac anomalies, most commonly tetralogy of Fallot and also VSD. And as you can imagine, the prognosis then would be worse. So when we have congenital interruption of a pulmonary artery, you'll notice that the lung on that side is small, it's hypoplastic. The opposite pulmonary artery, in this case the left here, will be enlarged. And because of the small volume here, this line that we see here really represents the anterior junction line that is shifted over to the right side because of the small right lung. And so the left pulmonary artery, if there's interruption of the right, will be enlarged in these cases. So here you can see the small right lung shifted junction line here, the anterior junction line, and then there are these reticular opacities here in the periphery, and what those represent are tiny collateral vessels. So these can be tiny collateral vessels from the periphery. They're arteries trying to supply the lung there. So in this case, you can see the left pulmonary artery here. Here's the interlobar pulmonary artery on the left. But notice there is no main right pulmonary artery here. There's congenital interruption of the right pulmonary artery. Now, there may be reconstitution more distally, so you can see a small interlobar vessel more distally there on the right side. So, again, here's the CT showing the small right lung, showing the shifted anterior junction line. These reticular opacities here in the periphery, these represent collateral vessels, transpleural collateral vessels from the intercostal arteries, trying to supply the lung on that side. Here's a 30-year-old who had a PDA. There's a right aortic arch here. There's congenital interruption of the left pulmonary artery. Notice the left lung is small. You can see the right pulmonary artery. Don't see much in the way of vessels there on the left side. Also a little patchy ground glass opacity there. And here we can see there's absence of the left pulmonary artery, and you can see the consolidation. So what's the cause of the consolidation that can be seen in these cases? Well, the lung on the side of the interruption is supplied by small arteries, and those are under systemic pressure, and you can get bleeding. So hemoptysis is a complication, so this can represent pulmonary hemorrhage. Also, these patients are also more susceptible to infection, so there's an increased incidence of pneumonia in these patients. So these patients with congenital interruption can develop consolidations both from pulmonary hemorrhage and also secondary to pneumonia. So here you can see the big right pulmonary artery in this case, no pulmonary artery on the left side, and notice all of these arterial vessels here that are coming off the descending thoracic aorta here. These are actually dilated bronchial arteries trying to supply the lung on the left side. Again, these vessels are under systemic pressure, so when they dilate and become tortuous like that, there's an increased risk of bleeding, which can cause pulmonary hemorrhage and will cause the consolidations that we might see associated with these patients. So here's an example of an interrupted right pulmonary artery here. And then here you can see the right pulmonary artery, the left pulmonary artery we don't see, dilated here vessels supplying the lung on the left side. So this is an example of an interrupted left pulmonary. Here in our next case, what we see is some funny looking vessels on the right side. And when we do pulmonary angiogram, you'll notice all of these branch stenotic lesions within the pulmonary vessels. So all of these tiny branch stenoses in the pulmonary vessels. What congenital infection can cause this? That's my next question. Okay, so we'll give you 5 more seconds on this one. 5, 4, 3, 2, 1. What did we say? And no, not Wegener's. Well, what infection? What's the infection we're looking for? So the infection we're looking for is rubella. Congenital rubella can cause those types of lesions. So pulmonary artery branch stenotic lesions, they can be multiple and bilateral. They can be associated with other intracardiac defects. You can get it with congenital rubella. You can also see it with Williams syndrome, which we've covered before. And as you might expect, that can cause pulmonary hypertension and right ventricular strain because of the obstruction of these small pulmonary vessels. And if they are proximal enough, if the stenotic lesions are proximal enough, they might be able to treat them with balloon angioplasty in those cases. Okay, so here's our next case, and in this case we have this funny looking vessel here on the left lung. And when we look at that vessel in close up, it's funny looking curled vessel here on the left side. So let's look at it some more here on a CT angiogram. We can see this tortuous vessel going all the way out to the periphery of the lung. There you can see it there, and there's another vessel that seems to be coming back here. So here it is when we look at it here on the volume rendered imaging. Here's the vessel going all the way out, a little bit tortuous, coming back. Here's a pulmonary vein over here. So we're trying to figure out what's going on in this patient. So here are these vessels here from the top of the lung, going all the way out to the periphery, and then coming back here. This is a pulmonary vein. That's the left superior pulmonary vein that these vessels are coming back to. So this patient actually went to angiogram. Here's the arterial phase, here's the capillary phase, here's the venous phase. What's your diagnosis? All right, so we'll give you a few more seconds on this one. 5, 4, 3, 2, 1. What did we say? We said, no, it's not a pulmonary AVM. That's the point of this case. This is not a pulmonary AVM. A pulmonary AVM gives you early venous drainage because that's an abnormal communication between the artery and the vein. So what's happening here is during the arterial phase, we don't see the vein. During the capillary phase, we also don't see this large vein. We don't see it, though, until the venous phase. So this is a large tortuous vein that is not seen until the venous phase. So that is not a pulmonary AVM. That is a pulmonary varix. So that was the point of that case. So when we go back then to the CT, where it kind of looks like it should be a pulmonary AVM, it turns out that all these vessels, these are not pulmonary arteries, and that's why in CT you have to be very careful in tracing out these vessels. These turn out to be pulmonary veins. These are all pulmonary veins that are draining back. There is no AVM in this particular case. So, what is a pulmonary varix? A pulmonary varix is a dilated vein, and most commonly we see it like this. It might be the dilated vein as it is entering into the left atrium, as you see here, the right inferior pulmonary vein. In this case, this can be associated with abnormalities that cause elevated left atrial pressure, like mitral valve disease, mitral stenosis. That can give you a varix like this, where the vein enters the left atrium. Okay, so associated conditions that can do it, as we've discussed, mitral stenosis, mitral regurgitation. So that can cause that dilated vein here. So this is probably the most common varix that you might run into in terms of thoracic imaging, a dilated pulmonary vein as it is entering the left atrium, especially the right inferior pulmonary vein in patients who have mitral valve disease. But we may also have congenital varices that are more extensive, and you can have an anomalous single pulmonary vein. So here there's one dilated single pulmonary vein that is draining the whole right lung, but this is not anomalous pulmonary venous return in this case. So this vein is actually going where it is supposed to go. It is going to the left atrium. So this is a varix, a dilated pulmonary vein. And this particular appearance, this is called pseudo-scimitar syndrome because it looks like it should be a scimitar, but it is draining to its normal location. It is not draining to the inferior vena cava. So this has been called pseudo-scimitar. Okay. All right, so here's our next case. So this really does look like a pulmonary AVM here. So we have this tortuous vessel, dense enhancement here in our pulmonary CT scan. So serpentine vessel. So I'll tell you that that's a pulmonary AVM. What syndrome is associated with this finding? But realize that, again, whenever you're looking at CT and you see vessels like this, and you want to make sure that you can follow the vessels, that it is being fed by a pulmonary artery, and that it is being drained by a pulmonary vein. But I'll tell you that that is the case here. So we'll give you 5 more seconds. What syndrome? 5, 4, 3, 2, 1. And we said, yes, correct. Osler-Weber-Rondeau, HHT. That is the correct answer. All right, so pulmonary arterial malformations, these are abnormal communications between the pulmonary artery and the pulmonary vein. And so there are 2 types. These can be, so here you can see the pulmonary artery going to this bulbous mass here, and then here's the appearance of an early draining vein. That's what you see with a pulmonary AVM. So the 2 types are simple, where you have a single feeding vessel, or maybe complex, where there is more than one feeding vessel. So those are the 2 types of pulmonary arteriovenous malformation. And many times these are asymptomatic, although these can cause a right to left shunt. And if they're very large, they can result in dyspnea, cyanosis, brain abscesses, again, whenever you are bypassing the filtering mechanism of the pulmonary venules, microorganisms, and the systemic circulation can get direct access to the arterial circulation. And a large percentage of patients might have Rondeau Osler-Weber or hereditary hemorrhagic telangiectasia. That is autosomal dominant, and the lesions tend to be multiple. So if you see one, look very carefully throughout the lungs, look for other lesions. So on a chest radiograph, you might see a lobulated nodule like this, but you might see the vessels here going towards it, a feeding artery and a draining vein. You might see that on a chest x-ray. Here's an angiogram showing you the feeding artery and the draining vein in this pulmonary AVM. So on CT, you'll see a markedly enhancing nodule. You should be able to trace out the feeding artery and the feeding vein, and these lesions may be multiple. So you want to look very carefully. And treatment is embolization. So pulmonary AVMs are usually treated even if they're asymptomatic, if the diameter of the feeding vessel is greater than or equal to 3 millimeters. So let's move on to aortic arch anomalies. So here's our first case. So we can see somewhat of a tortuous aorta here. There's this right paratracheal opacity there, and I'll show you the lateral view. And looking carefully at the lateral view, you should be able to provide a diagnosis in this case. What is your diagnosis here? And the clue is look at the trachea. Notice the trachea here. That is the clue. So what is your diagnosis for this patient? So we'll give you 5 more seconds on this. 5, 4, 3, 2, 1. What did we say? We said left arch with an aberrant right subclavian artery. That is correct. It's a left arch with an aberrant right subclavian. So you can see the left arch here, and it looks like there's some kind of funny vessel going back here on the plain film. But on the lateral view, the key finding is this deviation of the trachea anteriorly. When we see that smooth deviation, that can be an indication of an aberrant subclavian artery back there behind the trachea. So that is the clue, plain film. And indeed, this patient has a left arch, and you can see this aberrant vessel. That's an aberrant right subclavian artery that is going across behind the trachea and the esophagus. So this deviates the trachea anteriorly, which is what we see on the lateral view. Okay. There's another example where we seem to have this mass behind the trachea in this case. So we talked about masses in Rader's triangle back here. So an aberrant subclavian artery, aneurysm of an aberrant subclavian artery, as we see here, it's a large aneurysm here of this aberrant subclavian artery that can give you a mass or an opacity in Rader's triangle. So what is an aberrant subclavian artery? So we'll see this in a small percentage of the population. So the aberrant subclavian arises as the last branch of the aorta after the left subclavian artery. So the order of branching, right common carotid, left common carotid, left subclavian. And then this aberrant right subclavian arises as the last branch, crosses over to the right side behind the esophagus and the trachea, usually asymptomatic unless the vessel is tortuous or aneurysmal. And in patients who are older, they can develop atherosclerotic disease or even aneurysms. And then they can get dysphagia lusoria or dyspnea lusoria from the mass effect on the trachea or the esophagus. Another common finding is the diverticulum of Commerell, which is dilatation at the origin of the aberrant subclavian artery. So dilatation here at the origin of the aberrant vessel, that is called the diverticulum of Commerell, and that is a common finding with an aberrant subclavian artery. Now, I've also given you this double arch diagram that you can study that kind of explains the embryology of the arch and the theory behind it. Depending on where the interruptions occur in this double arch diagram determines the configuration of the aorta. So you can study that on your own to try to make sense of different configurations of the aorta, which we will also briefly cover here. So the normal formation for the normal left-sided arch, remember the arch is usually left-sided, the order of branching, we have the right brachiocephalic artery, the left common carotid artery, left subclavian artery. Notice the ductus arteriosus or ligamentum arteriosum here will be on the left side, anterior to the airway. So how do we get this when we start with the double arch model? Well, there is an interruption that occurs here in this model just distal to the right subclavian artery. And when that interruption occurs, then this embryologically can go on to form this configuration, which is the configuration of our normal left-sided aortic arch. So how do we get an aberrant right subclavian? Well, the interruption just happens to occur here, just between the right common carotid artery and the right subclavian artery. And then when that happens, the subclavian maintains its connection to the rest of the arch, and then this embryologically goes on to form this here. And we get then an aberrant right subclavian artery here going behind the trachea and the esophagus with the diverticulum of Commerell, as we see there. And notice that the ligamentum is still here on the left side. This, although it kind of goes around, this does not form a complete ring. So we do not have a complete ring here when we have an aberrant right subclavian artery. The clue to an aberrant subclavian artery always is this indentation behind the trachea and the esophagus. If you do an esophagram, you may see the smooth indentation behind the esophagus. That's the clue that you have an aberrant vessel back there, an aberrant subclavian artery that is crossing behind the esophagus. And so here, another example here of this aberrant right subclavian artery. As we follow it up, you can see that, and you can see the order of branching as we've discussed before. So the aberrant subclavian is the last vessel here that comes off the arch and then goes over to the right side. Okay. And then here on the sagittal reconstruction, you can see the aberrant subclavian artery there behind the esophagus, and it can push the esophagus and the trachea anteriorly. Here's the aberrant subclavian, a little diverticulum of Commerell there. And this explains what we see on the lateral chest radiograph. So the smooth anterior deviation of the trachea on the lateral chest radiograph is often a clue that you have an aberrant subclavian artery. And if the arch is on the left side, the aberrant subclavian will be on the right side. So the aberrant subclavian is always on the side opposite the arch. All right, so here's another case. So let's look at this case. Here we have, again, I ask you to look very carefully at the trachea there and tell me what your diagnosis is in this case. Okay, so we'll give you 5 more seconds here. 5, 4, 3, 2, 1. What did we say here? We said right, we do have an aberrant subclavian artery in this case, but where is the arch? It's a right aortic arch with an aberrant left subclavian. So look carefully on the frontal chest x-ray. You see this right paratracheal opacity this time. But again, we have this opacity there behind the trachea, so we're thinking of an aberrant subclavian. And in this case, it's a right aortic arch with an aberrant left subclavian artery. And notice again the diverticulum of Commerell here at the origin of the aberrant left subclavian. And again, the aberrant vessel goes behind the trachea and the esophagus to get from one side to the other side. And that explains what we see on the lateral chest radiograph. So this case here looks like we have a widened mediastinum, so you might think of mediastinal masses and lymphoma, but it's very smooth widening of the mediastinum there. And when we look at the CT, this is what the CT looks like in this case. So what do we call this? What's going on here? So here's the ascending aorta, descending aorta. Here's the arch right over here. What's going on? All right, so we'll give you 5 more seconds on that. 5, 4, 3, 2, 1. What did we say? So there is a diverticulum of Commerell. No, it's not a double aortic arch. No. It's, again, this is a right aortic arch, but this one is descending on the left side. Before I showed you a case of a right aortic arch descending on the right side. This time, this right arch here, the descending thoracic aorta, is found on the left side, which gives you this funny appearance here on the chest radiograph. Here's your diverticulum of Commerell, where you're going to get the aberrant subclavian artery. Right? So, is another example of a right aortic arch. What kind of right aortic arch is this? What do we call this? And what is the significance? If you look carefully at the chest radiograph, you may be able to tell me the significance of this right aortic arch. Okay, so we'll give you 5 more seconds there. 5, 4, 3, 2, 1. What did we say? Yes, that is a mirror image right aortic arch, and that is associated with congenital heart disease. And in this case, this is a case of tetralogy of Fallot. So this is mirror image branching here. So the branching pattern here is the mirror image of what we would see normally. So this is called, there is no aberrant subclavian artery in this case. So this is called mirror image right aortic arch, and that tends to be associated with congenital heart disease. And in this case, you can see the findings of tetralogy of Fallot, decreased pulmonary blood flow, elevated apex, that boot-shaped heart. So that's a patient with tetralogy of Fallot. So here's another case here. So here's the trachea. The trachea here is deviated a little bit to the left side. We see a right paratracheal mass. And when we see a configuration like that, we don't see the arch on the left side. So we suspect that this patient must have a right aortic arch. So here's an angiogram on this case. And when we look at the angiogram, so this vessel looks like the left common carotid here. Where is the left subclavian? Where is the left subclavian here? So let's take a look at that. There's your left common carotid. Here we can see our right common carotid. Here's the right subclavian. What about the left subclavian? How do we explain the appearance here of the left subclavian artery? And then I will show you here, this is an injection into the left common carotid. Direct injection into the left common carotid. Here's the subclavian. What's the diagnosis in this case? what do you suggest as your diagnosis here? How do you explain this? So we'll give you 5 more seconds here. 5, 4, 3, 2, 1. And what did we say? We said there is subclavian stele. This is a form of congenital subclavian stele, and this is from an interrupted left subclavian, which we can also see with right aortic arch, or an isolated left subclavian. So what's happened here is the left subclavian artery here is no longer connected to the aortic arch. So how does it fill? It fills from retrograde here from the vertebral artery. So this is a form of congenital subclavian stele. In this case, the patient does have a right arch. So this is a very unusual form of right aortic arch. This is a right arch with an isolated left subclavian artery. So here's the volume rendered view here showing you the left subclavian artery is not connected to the arch, and it is filling retrograde then from the vertebral artery, the form of congenital stele. So, right aortic arch anomalies. The side of the arch is determined by its relationship to the trachea. If the arch is to the right of the trachea, it is a right arch. If the arch is to the left of the trachea, it is a left arch. Think of an aberrant subclavian as being the last of the great vessels to come off the arch. If there is an aberrant subclavian, it is always on the side opposite the arch. So, if you have an aberrant right subclavian, then you have to have a left arch, and if you have an aberrant left subclavian, you have to have a right arch. So the aberrant subclavian will always be opposite the side to the arch. So in terms of the right aortic arch anomalies, there are 3 that you need to know well. Right aortic arch with aberrant left subclavian is the most common. Mirror image right aortic arch, the significance of this is that it is usually associated with congenital heart disease, and right aortic arch with isolated left subclavian, that's the rarest form of right aortic arch, which you might also occasionally run into. So the incidence of congenital heart disease with right aortic arches, if there's mirror image arch, then congenital heart disease is much more common, especially if you're dealing with infants. So with mirror image right aortic arch, 98% of those patients, especially as children and infants, will usually have congenital heart disease. But when you have right aortic arch with aberrant left subclavian, for the most part, if you encounter this in an adult, there usually is no associated congenital heart disease. So a right arch with an aberrant left subclavian is usually an incidental finding in an adult. On the other hand, the mirror image arch you would be more concerned about. So the right aortic arch with an aberrant left subclavian, that's the most common type. The order of branching of the vessels is here almost normal, except the left subclavian becomes the last vessel. There's a low incidence of congenital heart disease, and the aberrant left subclavian is retroesophageal. Now, this can be associated with a vascular ring if there's a left ductus connecting to the left subclavian, although it tends to be a loose ring. So most patients are asymptomatic. So how do we get this embryologically? The interruption here then occurs between the left carotid artery, the left common carotid, and the left subclavian. And when that happens, then we get a right arch with an aberrant left subclavian artery. Notice the ligamentum here is still on the left side, so this does form a complete ring. So in terms of anomalies that form a ring, this really is the most common anomaly that forms a ring, vascular anomaly that forms a ring, but the ring tends to be loose. So these patients are usually not symptomatic. So the right arch with the aberrant left subclavian artery. So you can see the indentation here of the right arch and the aberrant left subclavian there on the esophagram. And on CT, right arch, aberrant left subclavian. Often we have this diverticulum of Combrel, as you see there at the origin of the left subclavian artery. Now, the case that I showed you earlier, where we have a right arch, aberrant left subclavian, but the descending aorta is on the left side, this is called a circumflex aorta, where the aorta kind of goes around here the trachea and the esophagus. So when you have a right arch, although the right arch usually descends on the right side, it may also, and then it makes its way to the left, it might descend on the left side, as in this case. And when you have that right arch, aberrant left subclavian, with the descending thoracic aorta on the left side, that is called a circumflex aorta, as the aorta kind of wraps around here the posterior border of the esophagus. So that can give you this a very puzzling appearance on the chest radiograph. So we've talked about right arch with aberrant left subclavian. This is the most common vascular ring, usually not symptomatic though, because it is a loose ring. So you need to remember that. And then here we have another example here of a right aortic arch here. And we have this arch crosses over, descends on the left side. Here again is our aberrant left subclavian. There's a nice diverticulum of Commerell there. And so why do we get a diverticulum of Commerell? Well, in this case, in this volume rendered image, so here I've indicated the ligamentum arteriosum here. So what happens is the diverticulum of Commerell gives you an indication of where the ductus arteriosus was. So in embryology, the blood flow going through the ductus arteriosus would result in increased blood flow going through this portion of the vessel. So that portion of the vessel there then would remain dilated as the blood flow goes through there, through a pain ductus into the pulmonary artery. But what happens is once this closes off and becomes the ligamentum arteriosum, you're still left with this area of dilatation, which we call the diverticulum of Commerell. So the diverticulum of Commerell gives you an indication of where the ductus arteriosus was and where the ligamentum arteriosus is now. So that's where we get this diverticulum of Commerell. Now we talked about the mirror image right arch, and you need to know that that is associated with congenital heart disease. So in mirror image branching, the branching pattern is simply the mirror image of the normal branching pattern, commonly, especially in children and infants, associated with cyanotic congenital heart disease, most commonly tetralogy of Fallot, but we've also discussed truncus arteriosus in these cases. And here the ductus and the ligamentum again tend to be there on the left side, so this usually does not form a ring. So the interruption here occurs on the left side here of this double arch model, and that's what then results in the mirror image configuration when we have a mirror image right aortic arch, usually not associated with the ring. The right arch with the isolated left subclavian is probably the most interesting here, and this results in the subclavian artery losing its connection with the aortic arch, hence the left subclavian winds up filling retrograde from the vertebral artery, so this is a form of congenital subclavian steal. So how does this occur? Well, you get two interruptions here in this embryological model, and those two interruptions then result in isolation of the left subclavian artery. And in embryology, that can be filled through, you can see the ductus arteriosus may connect to that, but when that closes off, then what's left to fill the vessel? Well, the only thing left is the vertebral artery, and that's why these patients then develop congenital subclavian steal. Okay, so here's our next case. So we have a chest radiograph in this patient who has some shortness of breath. So looking at that chest radiograph, what might you suggest as the diagnosis here? Okay, so we'll give you a few more seconds, 5 more seconds there. 5, 4, 3, 2, 1. What did we say? We said, yes, that is a double aortic arch. And the clue is you have two opacities here, one on the right, one on the left. Notice this one indents the trachea. Whenever you have a vascular opacity that kind of indents or moves the trachea, then that's usually an aortic arch because it's going to be under a lot of pressure. So when we see that, then we think of the aortic arch. And usually with double arch, the right arch does tend to be higher than the left arch. So this is an example of double aortic arch. And So here then, embryologically, we maintain the double arch. So you'll have a right arch on the right, left arch on the left. The great vessels arise symmetrically from each of the arches. And this is the most common symptomatic vascular ring. In other words, if you have this anomaly, you're most likely to have symptoms with the double aortic arch. So double aortic arch, the ascending aorta then splits into the right and left arches. Great vessels arise symmetrically from that, and then they reunite to form the descending thoracic aorta, and this forms a complete vascular ring and can result in compression of the trachea. So with double arch, we maintain the embryology here, and this is the most common vascular abnormality to cause compressive symptoms in infancy. The right arch is usually larger, higher, and more posterior than the left arch. Usually the aorta descends on the left side. Interestingly, this is usually an isolated anomaly. It is not associated with an increased incidence of congenital heart disease. So we can see narrowing of the trachea with opacities there on both sides of the trachea when we have double aortic arch. So here's an angiogram showing the ascending aorta, double arch here, descending aorta where they unite, and then the great vessels arise symmetrically from each of the arches. So you can see the indentation here behind the esophagus from this double arch. So right arch, left arch. So pretty easy on imaging to make the diagnosis here as you see two complete arches on each side, and then you'll see this double impression here on the esophagus, on the esophagram from the double aortic arch in these cases. And then just when you think you finally understand it, you get a case like this. Here's a 28-year-old who has a right arch, no evidence of congenital heart disease. So what kind of arch should this be? Well, this should be a right arch with an aberrant left subclavian artery, right? So we're going to look for a vessel that's crossing behind the trachea and the esophagus, but what happens is there is no aberrant subclavian artery here in this case. And then when we look at the branching pattern here, this turns out to be mirror image branching because the first branch here coming off is the left innominate artery, which will give you the left carotid and the left subclavian, and then you're going to have the right carotid and the right subclavian. So this is a mirror image branching pattern. This patient should have congenital heart disease, but this is an adult with no congenital heart disease. This is a mirror image right arch. So how do we explain this? Why do we have a mirror image arch with no congenital heart disease in this case? Another clue in this case is that there is this small diverticulum here. There's this retroesophageal diverticulum telling us where the ligamentum arteriosum is, right? So that's the ligamentum arteriosum coming off attached to that small diverticulum. And it turns out that this is another form. There are two forms of mirror image right arch. There's a mirror image right arch type 1 and a mirror image right arch type 2. It is the type 1 that is associated with congenital heart disease. Type 2, though, is not. And the difference is with type 2, the interruption here occurs just distal to the ductus arteriosus, which allows then this diverticulum to form here, connecting to the ductus from descending thoracic aorta, which then is the clue that you're dealing with a mirror image type 2 aortic arch. So the interruption there occurs in this location here with mirror image type 2, and you can see that diverticulum here. Here's the ligamentum. So this also forms a loose vascular ring, and this is not usually associated with congenital heart disease. So what is the clue? Well, you have an adult with mirror image arch who does not have congenital heart disease. Look very carefully. Look for that retroesophageal diverticulum indicating where the ligamentum arteriosum is, and then that tells you that we're dealing with mirror image aortic arch type 2, the type usually not associated with congenital heart disease. Okay, so for our next case, we have a child with breathing difficulty. You can see some narrowing of the trachea, a little bit of anterior indentation there of the trachea. There's a little indentation there of the trachea there. So we see this vessel, which is causing the narrowing of the trachea and this indentation. What is our diagnosis? What do we call this? So 5 more seconds. 5, 4, 3, 2, 1. What did we say? We said, no, this is not a pulmonary sling. This is no. This is not a pulmonary sling. So this vessel here that's causing the indentation of the trachea, it's an artery, right? So this artery is coming off the aorta. So what is this called? That's the innominate artery. So that is called innominate artery compression syndrome. So what happens is the innominate artery arises a little more distally from the arch, and then when it crosses over there, it causes that anterior compression on the trachea, which can cause respiratory distress. So this is innominate artery compression syndrome. So this vessel here represents the innominate artery as it is going across, causing this anterior indentation on the trachea. So you can see the innominate artery, it's originating a little bit further to the left than normal, and as it crosses over, it can compress the anterior portion of the trachea. And so anytime there's tracheal compression in embryology, you can develop tracheomalacia, you can develop this abnormal narrowing of the trachea, so that can occur with any vascular anomaly that causes compression of the trachea. Similar to that, you can have an anomalous left common carotid artery, where the left common carotid originates too proximally, and then that crosses, causing an anterior indentation of the trachea. But the innominate artery compression syndrome is the one you should be aware of, as that one is more common. Okay, so you've been you do need to recognize this. So what's our diagnosis here? Should be able to say just from that one image, we think this is. And the clue is, some of you have been waiting the whole conference for this, as I've seen this answer pop up just about on every case. So we'll give you 5 more seconds. 5, 4, 3, 2, 1. What did we say? This is the pulmonary sling, right? Finally, your pulmonary sling, right? So what is a pulmonary sling? Well, this is where we have an anomalous left pulmonary artery that's coming off the right pulmonary artery. It's the right pulmonary. So the left pulmonary artery comes off the right, and then it goes across between the trachea and the esophagus, and that can result in compression, this vascular compression and narrowing of the airway. So that is a pulmonary sling. So here it is, volume rendered. This is an anomalous left pulmonary artery actually coming off the right and then going across to the left between the esophagus and the trachea. And the complication from this here is your anomalous left pulmonary artery. Notice it is between the trachea and esophagus. And that is the big clue, is that this is the only vascular anomaly really where you have a vessel going between the trachea and the esophagus. So if you see that, you're going to think pulmonary sling, and you can see here on this virtual bronchoscopy how it can cause narrowing of the airway. So as we go down the airway, you can see the extrinsic compression there on the airway wall, and this can result in respiratory symptoms from narrowing of the airway. So on the clue also on plain film, you can see an indentation here between the trachea and the esophagus. So whenever you see that, you're going to think pulmonary sling. See the pulmonary sling going across, diagram here, between the trachea and the esophagus. So that is a vascular sling, aberrant left pulmonary artery. And because of compression on the trachea, it can result in congenital anomalies of the trachea. And so here then you can see, in addition to this abnormal bronchus here, you can also see this diffuse narrowing from tracheomalacia here. So any vascular compression of the trachea during embryology can result in tracheal narrowing. And then here you can see volume rendering of the airways, and you can see the narrowing of the airways here where the pulmonary sling is going across because of compression on the airways. So you do need to recognize this. It can also result in atelectasis of the lung from compression of the airway. So you can get air trapping and atelectasis with this disorder. And I'm just emphasizing this multiple times because this is a very typical board question. So if you see an indentation like that on a barium study between the trachea and the esophagus, you need to think vascular ring. So that's an anomalous left pulmonary artery. Here it is on imaging. Here it is on bright blood going across here between the trachea and the esophagus. And then here, volume rendered view showing you that anomalous pulmonary artery going across between the trachea and the esophagus. And interestingly, this can also result in decreased blood flow to the left lung. So if we do phase contrast study here on that anomalous left pulmonary artery going across, notice you have lots of blood flow through the right pulmonary artery, but the blood flow through the left pulmonary artery is diminished. So there can be decreased blood flow here. It can also result in a smaller size there of the left lung. So that's what we can see with a pulmonary sling. So it's important to know what the appearance is on barium study for these various vascular anomalies. If we have a complete vascular ring, we can have indentation anterior to the trachea and posterior to the esophagus. If we have an anomalous innominate artery, we can get an indentation here anterior to the trachea. An aberrant subclavian artery will always give you an indentation here posterior to the esophagus, and the pulmonary sling is the only vascular anomaly that gives you an indentation like this between the trachea and the esophagus. So things that can give you a complete vascular ring: double aortic arch, that's the most common one to be symptomatic. Right arch with left subclavian, that can also give you a vascular ring, although that tends to be a very loose vascular ring. And then we talked about mirror image right arch type 2. That can also give you a vascular ring, but again, that tends to be a loose vascular ring. Okay? All right. So that is our discussion